the on button here. Yeah. Good morning, everyone. In the interest of time, I think we'll go ahead and get started with plenary session number 7. These will be 5-minute presentations with 2 minutes for questions. We did have one presenter with 3 presentations unable to make it, so we have a little bit of extra time, but we'll try to stick to the schedule of 5 minutes for presentations and 2 minutes for our Q&A. My name is Michael Edwards. I am a robotic and bariatric surgeon from the Mayo Clinic in Florida.
Good morning. My name is Brian Daly. I'm a acute care surgeon at the University of Tennessee Medical Center at Knoxville. I'll just say I have a perspective that I've been a surgeon over 2 centuries. So is Dr. Strawn here? You ready to present? So we'd ask all the presenters to keep the program flowing, to just be aware of where you are and where you are in the program. So the Orlando program will not be presenting. So if you look on your schedule and you're behind them, please move ahead.
All right, so our first presentation is safety of the trauma quality improvement program guideline for venous thromboembolism prophylaxis in trauma brain injury. Authors are Strawn, Johns, Perel, and Ashley. Our presenter is Dr. Strawn. Allison Frenzy from Navicent Health, Mercy University School of Medicine. Podium is yours.
Thank you. Good morning. Good morning. I just wanted to thank the Southeastern Surgical Congress for the opportunity to present my research. Go to the next one. Never mind. Sorry. I have no disclosures. So part of why we started investigating this topic of research is because it's widely known in the trauma population that patients with traumatic brain injury or TBI are particularly susceptible to venous thromboembolism events or VTE. It's estimated that the incidence is 25% in these patients, and it's the 3rd leading cause of mortality in TBI patients if they survive after 2 days. So studies have really focused on early initiation of VTE prophylaxis within 24 hours, or if you're looking at the big landmark paper, Byrne Norwood, 48 hours, it greatly reduces the risk of VTE. However, between neurosurgeons and trauma surgeons, there's a big discrepancy about when we should actually initiate VTE prophylaxis because of the hypothetical risk of worsening hemorrhage. In 2015, the American College of Surgeons issued a trauma quality improvement program, issued a guideline for initiating VTE prophylaxis in the TBI patient population, which we adapted in 2017. So we hypothesized that implementation of the ACS TQIP TBI guideline would have a low progression of intracranial hemorrhage in our blunt TBI patient population. This was a single center retrospective review of TBI patients who received chemical VTE prophylaxis per the ACS TQIP best practice guideline from July 2017, which is when we initiated it, to December 2020. It was approved by the IRB review board, and patients received heparin or low molecular weight heparin per the modified Byrne Norwood criteria. Here's the modified Byrne Norwood criteria. It differentiates patients whether they're low, moderate, or high risk. For our study, we excluded those that were high risk. In low risk patients, it's recommended to start VTE prophylaxis if a CT is stable at 24 hours. In moderate risk patients, it's recommended to initiate VTE prophylaxis if CT is stable at 72 hours. Our inclusion criteria included patients that were greater than or equal to 18 years of age, a length of stay greater than or equal to 2 days, non-pregnant patients, and adherence to the guideline. So we separated our patients into 2 separate groups. Our first group is patients that did not have a CT scan that we could look at after initiation of VTE prophylaxis. In these patients, we did an extensive chart review to evaluate their Glasgow Coma score and looked at physician notes, nursing documentation to see if there was any evidence of neurological decline. And this would allow us to estimate whether or not they had progression of bleed. And then in our second group of patients, these patients had a CT scan after initiation initiation of VTE prophylaxis. We had one board certified radiologist review all of these CT scans. He compared these CT scans in sequential order and noted the bleeds to have no change, which was less than 3 millimeters of an increase in bleed, an increase in brain bleed greater than or equal to 3 millimeters, a new bleed, or whether it had resolved. So over this period of July 2017 to December 2022, we had 12,922 patients admitted to our trauma service. 552 had traumatic brain injury, and 269 of these patients met inclusion criteria. We had 214 patients in our clinical confirmation group. We had 55 patients in our CT who had a CT brain after initiation of VTE prophylaxis. This equals the 269 patients. So overall, in our clinical confirmation group, we had 0 of 214 patients with progression of intracranial hemorrhage. And then in our group that had a CT scan after initiation of VTE prophylaxis, 0 of 55 patients had progression of hemorrhage. So what does this all mean? So not a single patient from either group had progression of hemorrhage after initiation of chemical VTE prophylaxis per the ACS TQIP guideline in our blunt TBI patient population. So this really does support what Norwood and Byrne suggested many years ago, that initiation of low molecular weight heparin should be administered early in patients with blunt TBI. So in conclusion, initiation of the TQIP TBI VTE prophylaxis guideline was found to be safe with no progression of intracranial hemorrhage in our blunt TBI patient population. Thank you again. I'll take any questions.
Thank you, Dr. Francis. So we do not have invited discussants for this session. So the floor is open for questions.
Well, I'll go ahead and start.
Yes, sir.
What was the length of stay of your low injury patients?
It had to be greater than 2 days, but normally about 2 days.
And do you continue the DVT prophylaxis after
After they're discharged?
they're discharged?
No, sir.
And,
Unless they meet certain criteria too, like if they had something that
and
would
do
require.
you have any follow-up as to those 214, for example, return with an enlarged subdural or any other data like that?
I was the one who extensively reviewed this, and I did not see any of those 214 patients. They didn't have any follow-up that, had an enlarging subdural in that patient population. Those are good questions.
What were you guys using for VT risk assessment? Was there a specific tool, Caprini, or some other tool in terms of risk of development of VT while in hospital and also at discharge?
Other than using the modified Byrne Norwood criteria, every patient and every trauma patient started on VTE prophylaxis if they are
okay.
meet the criteria.
Were there any differences? I know you talked about bleeding outcomes. Are there differences in terms of VT outcomes in the early versus late initiation?
There was not. That's why we didn't include it. Thank you for asking.
Okay. Any other questions? Thank you very much. Great
Thank you, guys.
presentation. Well,
Our next presentation, delayed tracheostomy after cervical fixation is not associated with improved outcomes. The TQIP analysis will be presented by Emma Kelly from the University of Tennessee Medical Center in Memphis.
Great. Thank you for having me this morning. We have no disclosures. So patients with cervical spine injuries are at a high risk of respiratory failure. If you look in the literature, anywhere from 20 to 80% are cited as ultimately requiring tracheostomy in the course of their care related to their cervical spine injury. When we reviewed the literature and discussed this with our neurosurgery colleagues, we often come to a discrepancy between when to perform tracheostomy after these patients undergo their cervical fusion surgeries. Probably the biggest theoretical concern that the neurosurgeons relate to us is that the tracheostomy secretions increase the risk of cervical site infection. However, in March of 2022, the ACS TQIP guidelines were published for spinal injuries, and they stated that you can do early tracheostomy in this patient population. When we look closely at these guidelines, we found that they were only supported by smaller single institution studies. So we saw an opportunity to delve into the TQIP data and kind of confirm that this guideline was good. So our hypothesis was that there would be no association between early tracheostomy and surgical site infection. All right. So we queried the TQIP database and used ICD-10 codes for cervical fusion and tracheostomy to highlight our patient population. We also excluded patients who obviously did not undergo tracheostomy as well as operative spinal fixation at the cervical level. And then we also excluded patients with an AIS greater than 3 in any region other than the spine. And then, of course, we excluded patients with incomplete data regarding fixation of the tracheostomy. So this starting with about 3 million patients from 2017 to 2019. Again, we excluded all those patients who did not undergo operative cervical fixation or tracheostomy. We then excluded patients who did not have an AIS greater than 3 in any region other than the spine. And this is because the TQIP data does not allow us to specify where that surgical site infection is. So by doing this, we ensured that all the surgical site infections were specifically related to their cervical fixation site. And then we excluded patients with incomplete data, leaving us with a cohort of 1,400. Found no difference in rates of surgical site infection between the early and delayed tracheostomy groups. We also found no difference in rates of mortality between the early and delayed tracheostomy groups. What we did find was a significant association between delayed tracheostomy and increased ICU length of stay, increased hospital length of stay, and increased ventilator days. We also saw a significant association between delaying tracheostomy and composite morbidity. Again, so the surgical site infection rate between the two groups was about 1.4%, and there was no significant difference in rates of infection of the cervical site between the two groups, regardless of when they underwent tracheostomy. Similarly, there was no change in rates of mortality, regardless of when patients underwent tracheostomy. What we did see was that delaying tracheostomy was significantly associated with an increased ICU length of stay, an increased hospital length of stay, and increased overall morbidity for these patients, as well as increased ventilator days. When we took time as a continuous variable and did Pearson correlations, these findings held true for the delayed tracheostomy. So we found that delaying tracheostomy again was associated with an increased ICU length of stay, increased ventilator days, and increased hospital length of stay. So in conclusion, early tracheostomy is not associated with an increased risk of surgical site infection in patients who have recently undergone an operative cervical fixation surgery. Delayed tracheostomy in this population, however, is associated with an increased ICU length of stay, hospital length of stay, and ventilator days. Thank you. I'll take any questions.
The floor is now open for questions. I'll go ahead and start. I know it's hard to discern from such a large database, but were you able to associate neurologic status? Were you able to associate pneumonia? And were you able to determine the approach the neurosurgery team used?
Probably one of the bigger limitations was we weren't able to discern the approach. So certainly whether a patient underwent an anterior or posterior fixation, unfortunately, we were unable to see. We did have ventilator-associated pneumonia as a separate variable with no significant findings. And then ventilator-associated pneumonia was also part of our composite morbidity variable, which was also mostly made up of infectious outcomes. So catheter site-related infections, things like that as well.
And then how about neurologic injury, spinal cord injury?
I don't think we were able to find the level of spinal cord injury. We did have the presenting GCS, which was 15 for both groups.
I do have a question. I I sort of feel like we've been having the discussion around early versus late tracheostomy for a very long time in, a variety of surgical cohorts. And I think the data has been out there and has been pretty clear. Are there specific barriers to adopting some of these practice guidelines?
I think for us, at least at our institution, it always just comes back to, what our trauma surgery colleagues are saying and kind of the discrepancy that happens with our neurosurgery colleagues. And there's some dogma out there that unfortunately we're still working to fight. And then I'm not quite sure why it still persists.
Okay. And as part of your, it's not here in your presentation, but I'm assuming as part of your manuscript preparation, are you also looking at the cost burden associated with delayed tracheostomy?
I'm sorry, the cost burden?
Cost burden. Mhm.
We hadn't, but that's certainly a factor. Certainly when you extend ICU length of stay and hospital length of stay, the cost continues to build on the patient. And that's certainly just one additional burden that comes with being a complex trauma patient. So anything that we can do to alleviate that, we hope we'll do so.
Very good. Thank you, Dr. Kelly. Our next presentation is efficacy of thoracic computerized axial tomography in blunt trauma patients with high Glasgow Coma scale and low injury severity score. Authors are Wasfi, Harding, Hassan, Mamar, Fisher, Yapchai, Shapiro. Presenter is Dr. Tariq Wasfi.
Thank you. I'd like to thank the Southeastern Surgical Congress for allowing me to present this work. We have nothing to declare. Now, we carried this project because of the increased number of the CT scan, which they call it quote unquote routine and CT of every trauma patient walks in the emergency room. And we would like to see how is the efficacy of these CT scans, particularly in the chest CT. So we evaluate a patient who had routine chest CT and a blunt trauma with high Glasgow Coma scale and low ISS score. This is a retrospective analysis of 901 consecutive trauma patients. The level 1 and level 2 activation between 2017 and 2019. The data collected include the age, gender, comorbid condition, anticoagulant therapy, hospital and ICU length of stay, physical examination and chest X-ray, as well as the chest CT finding. We divided the patient into two groups. Those patients who had a negative physical exam, chest X-ray, and CT, chest CT. And the group 2 is patient with negative physical exam, negative or positive chest X-ray, and CT, chest CT. The statistical analysis was carried with the chi-square and the student t-test, and IRB approval was obtained for the procedure for the study before it's initiated. 461 patients who had physical exam, chest X-ray, and chest CT recorded was included in the study. Group 1 include 442 patients, and group 2, 19 patients. And the 19 patients in group 2 defined as those with negative physical exam, negative or positive chest X-ray, and chest CT. Comparing the two groups, there is a slightly older age group in the group 2, and anticoagulant therapy was relatively higher and statistically significant in group 2. And the length of stay based on those two factors, they are higher in the group 2. The finding in a group 2, in the 19 patients, 13 patients with negative physical exam and positive chest X-ray. 3 patients were negative physical exam and negative chest X-ray. 3 patients with positive physical exam and negative chest X-ray. The 13 patients with the negative physical exam and a positive chest X-ray. The finding was 3 incidental lung nodules, 2 compression thoracic vertebral fractures, 4 rib fractures, and 4 apical pneumothorax. The 3 patients with positive physical exam and a negative chest X-ray. 1 patient had non-displaced fracture of the sternum, 1 non-displaced rib fractures, and 1 patient had left breast hematoma. In the 3 patients with a negative physical exam and a negative chest X-ray with a positive CT, 1 has non-displaced right 10th rib fractures and 2 compression fracture of the dorsal vertebra. Therefore, in the 461 patients in the study, 442 patients had a negative physical exam, negative chest X-ray, and negative CT. Only 3 patients had a negative physical exam and a chest X-ray, had a positive CT. We concluded from our study in a blunt trauma patient presenting to the ED with a high Glasgow Coma scale and a low ISS score, when initial physical exam and a chest X-ray are both negative, routine chest CT is of little value. Thank you.
The floor is open for questions. So if ISS is calculated based upon the injuries found usually after CT, how do you discern who has a low ISS on presentation?
That's a good point. We actually, these ISS score was collected retrospectively, of course, after the patient was discharged and collected. So initially, we don't give an ISS score, but we look at the patient. So physical exam is important. One point I have to mention is that patient on alcoholism or inebriated for any other reason, it should not be included in the study. And that's why one of the reasons one have to be careful when exam patient on alcohol. And
quick question. So if I understand the focus of the study is to determine the predictive value of chest CT in the setting of a negative physical examination and X-ray. So I didn't see anything reported in your presentation, but was there a determination of the sensitivity, specificity, and negative positive predictive value of the chest CT?
no.
I sort of think that if you're looking to publish the data, it probably would be important to have those elements.
Yes, I think one of the, we actually did analysis on individual, what is the value of a chest X-ray by itself as compared to the chest CT? Well, of course, CT is more accurate in everything. The question is, does it clinically indicate if the patient is fully aware and he can respond in your physical exam, and you're going to do a chest X-ray on everybody. So if that's negative, then, you know, I don't think there's going to be very much help in a chest CT. If the patient is suspicious anticoagulant therapy or is in a question of mental retardation, or your physical exam is not actually done by a surgeon or a senior resident, then yes, by all means. But we're trying to not to get the ED doctor doing a routine CT scan on everybody, because that's what's happening now. We did routine on everybody, even after negative fast exam.
Yeah. So I don't necessarily disagree, but I think if you're trying to convince those ED physicians, I think having those values may be helpful.
Of course.
Thank you, Dr. Watson.
Thank you, sir.
Our next presentation, predictors of facial fracture in trauma patients. A retrospective review at a level 1 rural trauma center will be presented by Thomas Sanders from Grand Strand Medical Center. His co-authors are Rhodes, Bosia, and Biswas.
Hi, my name's Thomas Sanders. I'm an M2 medical student at the University of South Carolina in Columbia. It's the green button, right? How do we go to the next slide? Sorry. What's this button? Sorry. Okay, so facial fractures alone have a pretty low risk of mortality. But really they're more of a concern when you see them in a patient. So if a patient has a facial fracture, they can be sort of like a sentinel for higher risk injuries like a TBI. And of course, because of disability and deformity, they can have pretty high psychological and social impacts on these patients. So quickly diagnosing them and treating them can be very impactful for these patients. The rates and incidences of these fractures can vary a lot from country to country, from even between cities, and they vary by age, race, and sex. You see them more commonly in younger patients, and of course they occur much more frequently in male patients than female patients. But the variability is further complicated by those regional differences, and current statistics tend to be pretty region specific and only speak to the prevalence of the facial fracture, so they don't go much further to talk about the relative risk each of these factors can pose and whether or not a patient will have sustained a facial fracture. So that's what this study attempted to do for. So we're trying to define which adult patients at a regional level 1 trauma center are most at risk for a facial fracture. We looked at dates July 1st, 2016 to March 21st, 2021. We looked at all the trauma patients who are older than 18 years, and that equated to a total of 20,377 patients. So first, descriptive statistics were performed with Wilcox rank sum and chi-square tests in R. That's commonly what most studies stopped at. So then after that, we went on to do a logistic regression using SPSS to determine the effects the predictor variables had on the likelihood of a facial fracture. So here are the descriptive statistics. Just depending on your glasses prescription, you might not be able to read them, but important information. You'll see that majority of the patients sustained injuries due to falls, motor vehicle crashes, and motorcycle injuries were sort of our big ones. Specifically, you'll see that motorcycle injuries and assaults had much higher prevalences of facial fractures. Meanwhile, falls had relatively lower risk, and motor vehicle crashes slightly lower. You'll also see that the injury severity score was slightly higher, and then go on to the next stage. So then we went on to do the descriptive statistics. You'll see that trauma activation correlated with more likely to have a facial fracture as well as ISS increased. Also, they're more likely to have a facial fracture, and Glasgow Coma scale. So a more severely injured patient are more likely to have a facial fracture, and that GCS also shows that those patients are more likely to have traumatic brain injuries as well. Then we went on to the logistic regressions. You'll see that gender, this compares that females were less likely to have a facial fracture. That's pretty common across all studies. It varies by country. So in the US, just about all studies show that it's about like a 2-to-1 ratio male to female, but in other countries it can go as high as 20-to-1 just based on cultural differences. And then all the way down on mode of arrival, patients that arrived by helicopter were 1.35 times as likely to present with a facial fracture, as opposed to private vehicle or walk-in patients who were less likely. And then again, you'll see that injury severity score and Glasgow Coma scale remained significant. This mostly just summarizes that. Okay, here, and you'll see modes of injury. Assault was by far the highest predictor. So there's a 6.62 times higher likelihood they would present with a fracture. This, again, makes sense, kind of like the easy targets in assault. And then as we go down, you'll see motor vehicle crashes had lower likelihood. Meanwhile, moped and motorcycle crashes had higher. This is one that surprised me because, of course, motorcycles have more force, and Generally, those patients tend to present with higher acuity injuries, but of course, they're slightly less likely to have a facial fracture than a moped. And we believe that just came down to helmet use. A similar study recently showed that it was 75 to 80% of facial fracture patients in South Carolina weren't wearing a helmet at the time of their crash versus, and this summarizes that again. Just sort of in conclusion, so we use descriptive statistics to show sort of a unique population. Myrtle Beach is a pretty unique city in a lot of ways, but it's a very old city showing a disproportionately high number of fall injuries. And it also has, for 2 weeks a year, like one of the biggest motorcycle rallies, which made that also disproportionately high. Males presented a greater risk of facial fractures, and facial fractures are more likely to be seen in patients with more severe injuries. And of course, patients with injuries from motorcycle accidents, moped accidents, and assaults are at higher risk of facial fractures, and those from motor vehicle crashes were at a lower odds of sustaining facial fracture. Sorry, and then questions?
Well, nicely done. South Carolina does not have a helmet law, do they?
They do not. Myrtle Beach
So-
specifically tried to pass one, and then it was struck down by the Supreme Court.
Were you able to differentiate those helmeted from non-helmeted, and specifically those full face helmets from just the brain buckets? I'll just say in Tennessee, we are under constant assault to repeal our helmet law.
Mhm.
Virtually every year, we have to go to the legislature to maintain that.
I don't have the information, just like from the data we had access to, but there was a similar study at the hospital, and it was only really spoke to the fact that it was, I think, only 22% of motorcycle drivers were wearing a helmet, and only like 9% of moped riders were wearing a helmet when they presented to the hospital. And
Rack and Burns, East Tennessee State. Very nicely done as a second-year medical student. Do you have any data on whether these fractures were operative or non-operative? Because not all facial fractures are created equal. And at the end of the day, what do we take away from this that we should go back and change from a practice standpoint?
I
Thank
don't
you.
have that information specifically. On one of my charts, there was trauma activation. So, and these patients did have a higher trauma activation. And just going back, I mean, obviously, as you're driving back, wear your seatbelt and wear your helmet if you came on a motorcycle. But just helping you when a patient presents, just giving you a better sense of whether or not they'll have a facial fracture, if that's something you need to pursue.
I have a quick question. It was interesting about females being less inclined to have facial fractures. Any insight on that? And in your regression analysis, was that independent of mechanism of injury and injury severity?
It was. It definitely was like slightly less pronounced, but it was, I think, it was like 0.77 times likelihood to lower, but definitely there was like a difference in other studies that was able to show that women did have like higher rates of like fall fractures, especially older female patients, and much lower likelihood of suffering assaults, which definitely contributed to that, because that's one of your very like high likelihood of having a fracture modes of injury. I think it was, I think another study showed that women were presented with facial fractures like 4 times less, or men 4 times more in assaults specifically with facial fractures.
Excellent job. Thank you, Mr. Sanders.
Thank you.
Our next presentation is a national survey assessing variability in the management of traumatic cardiac arrest. Presenters Dr. Keelan Roche from East Tennessee State University. Co-authors are Quinn, Menino, Ventura, Brown, Lawson, and Burns.
Thank you. Thank you to Southeastern Surgical for the privilege of the podium to present our study, a national survey assessing the variability in the management of traumatic cardiac arrest. I'm Keelan Roach, Assistant Professor of Surgery at East Tennessee State University. Sorry, how do I? This one? Okay. We have no disclosures. Trauma is the 4th leading cause of death in the United States and the 1st leading cause of death under the age of 45. cardiac arrest is the second most common cause of death due to trauma. The mortality is high and the management is highly variable. Some trauma surgeons practice advanced cardiac life support in the setting of traumatic cardiac arrest, while others use advanced trauma life support only models. In 2013, the American Association for the Surgery of Trauma published criteria regarding when to commence, withdraw, or terminate treatment in traumatic cardiac arrest. However, this focused on the pre-hospital environment. There are currently no practice management guidelines regarding the management of traumatic cardiac arrest. The aim of our study was to understand current practice patterns. We hypothesized that these practice patterns would vary based upon patient demographics and location. We performed a mixed method survey study to the membership of the AAST, including closed-ended and open-ended questions. Participants were queried whether or not they ever performed advanced cardiac life support in the setting of traumatic cardiac arrest. If yes, they then answered a series of closed-ended questions regarding the components utilized, the duration, the indications, and the indications for termination. Both groups, the yes advanced cardiac life support and no advanced cardiac life support, then answered questions regarding instances of conflict, including legal, ethical, interpersonal, or otherwise. They were then offered the opportunity to answer an open-ended question regarding a description of said conflict. The qualitative data was inductively coded in Atlas TI. 203 surveys were completed for a response rate of 12%. Most of our participants were male over the age of 60 and in practice more than 20 years. There were representatives from all 50 states. 73.4% of respondents reported they utilized advanced cardiac life support in the setting of traumatic cardiac arrest, while 26.6% of respondents reported they never utilized advanced cardiac life support in this setting. There was a significant association with age and years in practice, such that those who were older and in practice longer were more likely to utilize ACLS in traumatic cardiac arrest. There was a significant association with state of practice. However, when this was broken down into region, this was non-significant, and there was no significant association with gender. Of those that reported using ACLS, there was variability in the components utilized, the duration, the indications, and the indications for termination. We see here the components utilized. Most participants utilized chest compression and epinephrine at 94% and 91% respectively. However, less than half utilized the other medications associated with ACLS. When looking at indications, most participants reported that suspicion of a non-traumatic etiology was a indication for ACLS, but about 70% also reported drowning, hanging, and lightning strike as indications for ACLS, while less than 50% reported the goal of organ donation as an indication for ACLS. 24% of those who utilize ACLS reported conflict, while 28% of those who reported not using ACLS reported conflict. Thus, there was no significant difference. We see here representative quotations of the qualitative data. When these were inductively coded, they were distilled down to 5 major themes, which included interpersonal conflict, futility, variability in practice, harms, and benefits. In conclusion, most trauma surgeons utilize some component of ACLS in the setting of traumatic cardiac arrest. However, the components utilized, the indications, the duration, and the indications for termination were highly variable. We also found that despite the fact that most trauma surgeons report using some components, there was significant conflict reported due to variability in practice. Our study highlights the need for practice management guidelines to reduce this variability. This is unlikely to change outcomes in an entity as ubiquitously grave as traumatic cardiac arrest, but could serve to alleviate some of the emotional distress as elucidated in this study. Thank you. I'm happy to answer any questions.
The floor is open for questions. So I'll make a comment. As we go through our 10th version of ATLS, the European community was very strong in recommending continued chest compressions. That's a point of great debate, which I'm sure will be brought up during the revision process. So Tell us what your view on chest compressions for traumatic cardiac arrest is.
So where I trained, practiced a ATLS only model such that patients who presented, we just initiated ATLS on their arrival to the bay. So that was how I was trained. Once I'm into practice, I see a number of different ways. I will say in my setting, I will typically continue chest compressions, remove the Lucas device if that's in place, but continue chest compressions, avoid the use of epinephrine.
So what do you see as the sort of true gap here? Is it a lack of true sort of evidence-based practice guidelines, or is it a compliance issue to current evidence?
So we do not have any current practice guidelines. So I think that's the biggest issue. I don't think we have a set standard to hold ourselves accountable to.
So your response rate was low. Do you plan to repeat the study, say at the next AAST meeting?
I would like to. Yeah, I hadn't thought about our next steps regarding that outside of working on development of the practice management guidelines. But I think, yes, a 12% response rate is certainly low.
Certainly in line with all other surveys. Yes, sir.
I don't think this thing's on, but no, it is on now. Brian Morse from Portland, Maine. Thank you for your presentation. That was actually very interesting. Speaking of traumatic cardiac arrest, when I see people performing CPR for traumatic cardiac arrest, it gives me immense chest pain. It really violates the physiologic principles of shock. I've done a lot of education as I've left Grady and gone to Portland, Maine in terms of how we're going to, resuscitate people. And it seems to be this, we've gotten somebody here who's arrested. Now, what do we do? I've had to overcome challenges with having people actually remove the Lucas device, which is a new addition for me coming from Atlanta. And then this whole concept. And when I hear traumatic cardiac arrest and ACLS, I guess my assumption is that somebody must think it's a traumatic brain injury.
I think it depends upon the time of presentation of that patient. If they meet criteria for resuscitative thoracotomy, then that is done. If they don't, then I think that's when we get into this realm of, do you do ACLS? What do you do in this setting? I think, the management for the peri-arrest blunt trauma patient should certainly include finger thoracostomies, establishment of our airway, all those steps. But, in addition to performing ACLS maneuvers, as you said, it's not the same as a cardiac arrest due to a heart attack. And so there's just not the evidence that we need to be doing all these things. And then when you give these patients epinephrine, you have a beating heart, and whether or not you have an alive patient is a whole nother question.
Yeah. Very good. Thank you very much.
Our next paper is Understanding the Impact of Retained Bullets from Survivors of Gunshot Injury. It'll be presented by Ricky Niedergaard from Emory University, co-authors of Smith, Meyer, D'Souza, Resnick, Ghosh, Blount, and Hennick.
All right, thank you very much. My name is Reike Müller-Niedergaard, and as probably the only person in the room, I'm not a surgeon. I am a public health professional specializing in mental health, and I'm here to talk to you about the psychological impacts of retained bullet fragments from the perspective of survivors. So as you know, we have a growing gun violence epidemic in this country. Every year, about 45,000 people die from gunshot injuries, but there's also 120,000 people who survive. And we know that about 3/4 of these have retained bullet fragments. So that's about 90,000 people a year. Psychological ramifications of living with retained bullet fragments are largely unstudied. However, a recent epidemiological study established a clinically and statistically significant association between retained bullet fragments and depression. We don't currently have international guidelines for when to remove retained bullet fragments, but a recent study suggested that mental health is only rarely a factor in these considerations. So what our study was aiming to do was to understand the link between retained bullet fragments and the psychological well-being of survivors. And the way we did that was to conduct a qualitative in-depth interviews with 24 survivors. We then did coding of this data and robust thematic analysis, and then developed an impact model. To our knowledge, this is the first study of its kind examining this relation from the perspective of the survivors. So if we're looking at the data collection we had 24 survivors, which were all recruited from Grady Memorial Hospital in Atlanta. They were predominantly Black and predominantly male. We did try to recruit for greater diversity, but this is largely reflective of the population that seeks care for firearm injury at Grady. The median age is 28, and the median time since injury was 8.5 months. So we found 4 main areas of psychological well-being that were impacted. The first one was physical health. So all patients reported pain, and those who had palpable bullets often associated that pain with the retained bullet fragments. They also would experience limited mobility, which meant they couldn't do things they'd been able to do before, which of course impacted their psychological well-being. And a lot of them would have impaired sleep. For example, we had one guy with a retained bullet in his arm. He would in the middle of the night roll onto his side, onto the bullet, and then wake up in agony. As you might imagine, this impacts people's emotional well-being. So it would cause a lot of frustration in these survivors. One participant said that pain creates anger. Other participants had flashbacks when they saw the retained bullet fragments. Some were fearful or paranoid about what living with retained bullet fragments would do to them. A lot of people felt ashamed about living with retained bullet fragments, especially female participants. But some even felt proud about it because they felt like they'd lived through something really difficult and gotten out stronger on the other side. These physical and emotional effects also impacted upon people's social lives. They were much less independent in the immediate time after their injury, where their families and friends needed to take care of them. But ironically, a lot of survivors felt a distance from their networks because they felt that they could not relate to the experience of living with a retained bullet fragment. One guy described it as being at a picnic where there's a bee flying around, but you're the only person who can see that bee and the only person annoyed by that bee. There also tended to be more conflicts in families because of some of the anger and frustration, some of this pain. These things then also impacted upon people's occupational lives. Even beyond the initial medical leave, a lot of people remained unemployed. Some people had to change the way they did their work, so they didn't do as much heavy lifting. Others did work at excruciating pain. We had one mechanic, he had a retained bullet in his shoulder. And when he was working with the cars, his shoulder would pop out. And he would have to pop it back in at excruciating pain past the fragments. Moreover, there was often also conflicts at work because of the frustrations here. Another interesting thing that came out of our study was that participants had 3 main ways of coping with living with a retained bullet fragment. The first one was processing, where they would use their social networks or religious networks and sometimes therapy. It was especially beneficial for patients who could talk to other people who also had retained bullet fragments because they then felt less alone. Essentially, they were working to find meaning, and a lot of people engaged in positive self-talk to try and change how they felt about it. Other people engaged in distractions that could be positive things like family time, but was often also substance abuse. Like we had a guy who would drink till he puked blood, a woman who couldn't fall asleep, who would drink till she blacked out. This, of course, didn't help them in the long term. And finally, we had people who were engaging in problem solving. So that means trying to move the bullets or the fragments because they felt they would never be fully fixed and would always be worried about the bullets in their bodies. One guy even dug into his abdomen and took the bullet out himself. All right, so in sum, our recommendations are that surgeons should consider the potential psychological consequences of living with retained bullet fragments when deciding whether to remove them. We recommend that you liaise with patients about the potential for bullet removal at follow-up appointments, and that there should be peer support workbooks where people can talk to other people who have retained bullets. That's something we've set up at at Grady with great success. And finally, we recommend further research to enable patients and surgeons to make informed decisions. And here are contact information. Thank you.
Thank you very much. Very nice presentation. The floor is now open for questions.
So I ask, did you do a depression inventory for any of the patients to see perhaps this is just the psychological or the physical manifestation of a psychological trauma?
So there's been a previous quantitative study which did use the depression scales, which compares the people who had retained bullet fragments to the one who'd gone through gunshot injuries but didn't have retained bullet fragments. And that found clinically and statistically significant association. For this particular study, we looked at it from the perspective of survivors without using the clinical guidelines for determining depression.
And then did you look at any other populations besides those of inner city violence, for example, veterans who may have the same retained fragments?
In this particular study, we looked at civilians who came to Grady Memorial Center. We would recommend further studies with other populations to try and determine how it might, for example, impact military personnel. I speculate that they might have more people to talk to about their trauma and their retained bullet fragments because they have friends who might have gone through similar injuries, and that might have helped them.
Caleb Butts, University of South Alabama. Thank you guys for presenting this stuff. This is stuff that's under-recognized in trauma. The work Dr. Smith as well as Dr. Punch in St. Louis has done on this has been great. Is there any association? I think the big thing is that we're trying to screen earlier for these people who have retained bullet fragments for potential intervention. Is there any indication that earlier intervention leads to decreases in the rates of PTSD and depression after this? Yeah, that's it. Thanks.
I think definitely further studies is merited on that. We do know as the bullets are removed, there is lessened depression symptoms. The previous study that Smith carried out didn't find an association with PTSD, but we did experience some people sort of had flashbacks when they sort of saw the injuries. So perhaps that would indeed help if you could get the bullets removed much earlier. But I also would recommend you talk to the individual patients because some actually felt like they wanted to keep them. That was the minority, but some of them said, hey, it reminds me of a time in my life that I overcame and I came out stronger.
Yeah. A very quick question. I know it's a small sample, but were there any correlation between location of retained fragments and psychological impact?
So in general, the people who had palpable bullets were more likely to associate with the retained bullet fragments with their symptoms. And the people who had bullets in the lower part of the bodies often wouldn't be able to walk, and that impacted how sort of independent they could be. People who had retained bullet fragments in the upper bodies more commonly struggled with everyday activities like showering and cooking or carrying out their jobs, which again also impacted upon their mental health because they couldn't go about their everyday lives.
Okay. Right.
We have one more question.
I'm sorry.
One more question, Brian Morse again from Portland, Maine. Which bullets do you recommend going after to take out? There's the ones that are like, and this is something we kind of struggle with as trauma surgeons. When people come back to the clinic, there's the easy ones that are palpable right under the skin, and then there's the ones that are laid down by the pelvis and the spine that are going to, require a major operation. Do all these bullets have the same psychological impact? And which ones do you try and remove? Thanks.
Thank you for the question. I think it's always weighing up how dangerous it is to remove a bullet versus how the patient feels about having that bullet removed and how the patient reports that impacts their lives. So if it's a bullet that's relatively easy to remove, we definitely recommend that that's something you should go for. Whereas if it's quite dangerous, it's worthwhile liaising with the patient about that and talking with them about how it impacts their lives. We also saw a lot of people who were scared about lead poisoning, for example. So it's worthwhile just in general advising them both about the psychological and some of the physical consequences of living with retained bullet fragments so they can make the decision alongside with you on an informed basis. Thank you.
Right. Thank you. Our next presentation is blunt traumatic abdominal wall hernias, an indicator for emergent laparotomy. Presenter is Dr. Adora Tricia Santos from Emory University. Co-authors are Jagiela, Lodis, Kim, Friedberg, Nguyen, Young-Chi, Smith, Benjamin, Todd, and Scarietta.
All right, good morning. My name is Adora Santos. I'm a first-year trauma critical care fellow at Emory University. Thank you to Southeastern Surgical for the opportunity to present our research on blunt traumatic abdominal wall hernias. We have no disclosures. Traumatic abdominal wall hernias are most commonly the result of significant shearing forces to the abdominal wall, leading to fascial disruption, and are most commonly the result of high energy blunt trauma directly to the abdomen. First described by Dr. Selby in 1906 as a disruption of the muscles and fascia, while the skin and peritoneum remain intact. They are a rare injury pattern with an overall incidence rate reported in the current literature between 0.17% and 1.5%. Because this is such a rare injury pattern, the optimal management of patients with a traumatic abdominal wall hernia with regards to the need for emergent exploration to evaluate for intra-abdominal injury, as well as the timing and type of repair of the hernia has yet to be determined. This is a CT scan that demonstrates a more traumatic abdominal wall hernia in a restrained passenger who sustained a high-speed MVC. Since Dr. Selby's first description of traumatic hernias, there have been several iterations of classification systems for traumatic abdominal wall hernias. The most recent grading system was designed by Harrod et al. In a multi-center trial and takes into consideration the anatomic region of the hernia, as well as the layer of the abdominal wall that had been disrupted, as previously described by Dennis et al. The aim of our study was to evaluate whether the presence of a traumatic abdominal wall hernia is associated with an intra-abdominal injury requiring laparotomy. This is a retrospective cohort study conducted at Grady Memorial Hospital, a high-volume urban level 1 adult trauma center in Atlanta. All adult trauma patients who sustained blunt abdominal trauma and was diagnosed with traumatic abdominal wall hernias on axial imaging between January 2012 and December 2020 were queried. In our patient cohort, we collected their demographics, including age, sex, BMI, and injury severity score. We also collected the type of hernia, as well as associated injuries, as well as the need for emergent operations and those who failed non-operative management and those who died. The primary outcome measured for this study was the need for immediate operative intervention. During January 2012 and December 2020, there were 38,749 patients that were admitted for traumatic injuries. Of these, 37 had a traumatic abdominal wall hernia. The majority of our patients were male with a mean injury severity score of 20. 21.6% had a clinical seatbelt sign, and almost 50% were a result of a motor vehicle collision. The majority of our patients had lumbar hernias, with left side hernias being more common than right. Almost 30% immediately went to the operating room for laparotomy for peritonitis, shock, or pneumatosis seen on CT scan. 6 patients underwent a bowel resection and 1 had a damage control laparotomy. Of the remaining 26 patients who did not immediately go to the operating room, 5 patients failed non-operative management and underwent exploration for peritonitis that developed and changes in hemodynamics with subsequent repeat imaging prompting exploration. 2 of these patients were found to have a hollow viscous injury, 1 a mesenteric hematoma that caused bowel ischemia. We had 2 patients undergo immediate hernia repair. 5 underwent delayed hernia repair, 3 with biologic mesh, and 2 primary repairs. We had no hernia recurrences and no mesh infections. Our average ICU length of stay was 9 days, and our average hospital length of stay was 20 days, and we had 2 patients died within this cohort. In conclusion, traumatic abdominal wall hernias is associated with intra-abdominal injury requiring emergent laparotomy. Non-operative management is feasible in the carefully selected patient with close observation. However, further investigation is needed to determine optimal timing and type of repair of these hernias. I would like to thank all of my co-authors for their work on this paper, and I'll be happy to take any questions.
The floor is open.
Hi, Jason Clark, I'm trying to help. Yeah, we find these pretty difficult to decide what to do, particularly in a stable patient. I guess my question is, you mentioned patients that you included that had shock. Did you only pull the patients that you identified with like ICD-9 codes, or all patients, all comers, or patients you specifically identified with CTs? Because I would think the ones that you identified with CTs would be a different patient than you found incidentally on an emergent trauma X lab.
So there actually is no ICD-9 or ICD-10 code for traumatic hernias. So these have all been pulled from the reads based on our CT scans. We did have 1 patient in our cohort that presented as in a delayed fashion that came in later on with abdominal pain that got a CT scan that was subsequently found to have a hernia.
So the question is, you have your stable patient comes in, the CT is negative.
Mhm.
With your false negative rate of your CT scans, do you operate on everybody initially?
I think in the correct setting, in the correct patient, I think it's feasible to just admit these patients for serial exams, serial labs, and if there's any changes in their exam or clinical picture, that would warrant exploration in these patients. I hope that answered your question.
Did all these, it sounds like your diagnosis was based on CT evaluation. Did all these patients have a pre-existing CT that documented no hernia? So were these all true traumatic hernias or some of these pre-existing hernias?
So that's one of the limitations of our studies, that we don't know who actually had hernias previously, but based on our injury pattern, with lumbar hernias being the most frequent, those are the ones that are mostly associated in the traumatic setting rather than a spontaneous or primary hernia.
Okay, and what's the primary argument for just not fixing all of them in the setting of your laparotomy?
I'm sorry.
What's the argument for not fixing all of them in that setting when you're in the OR? Why not just fix them?
So previous literature has stated a relatively high recurrence rate in when you fix these in the acute setting. So there have been several studies that do recommend waiting a period of time before going in for elective repair.
Okay. Any other questions? Dr. Santos, thank you.
Our next paper, under triage risk among those with intracranial hemorrhage in a regional hospital trauma network. That'll be presented by Taylor Locklear from Grand Strand. Co-authors Rhodes, Andersons, Pepe, Biswas, and Courtney.
Good morning. My name is Taylor Locklear. I'm a second-year surgery resident at Grand Strand Medical Center in Myrtle Beach, South Carolina. I'll be presenting under triage risk among those with traumatic brain injury in a regional trauma network. So a trauma system is essential to reduce pre-hospital setting to reduce preventable deaths and morbidity. While not overutilizing resources, and that kind of stems from our ability to appropriately triage patients and match their level of care with the level of care that they require. The level to which a patient is triaged is the primary assessment of whether they subsequently become over or under triage. So the Committee on Trauma allows for an under triage rate of less than 5% in our hospital system. This rate has been as high as 10% using the Cribari matrix method. In 2018, we made an outreach effort to educate our pre-hospital providers on triaging and identification of risk factors that we were able to recognize from prior studies of patients that were susceptible to under triage. And these were patients, typically older patients with a higher GCS that suffered blunt mechanisms and most notably falls. So these patients also had an increased risk of being under triage if they subsequently developed or had a TBI. So in this study, our aim was to identify methods to identify risk factors for patients that had TBIs in our under triage population. So we underwent a retrospective single system study with our trauma data from 2016 to 2022. We included individuals greater than the age of 40 that were transferred to our facility with traumatic brain injuries. And we diagnosed or identified under triage based off of the Cribari matrix method. We had 187 individuals that met this inclusion criteria, and 878 and 168 of those individuals experienced under triage. Similar distribution between males and females. And as we previously noted in prior studies, a lot of these individuals suffered blunt injuries, and a significant portion of them were low-level falls with a GCS around 13, so on the higher GCS ratio or score. What we found in our results through logistic regression analysis, multivariate, was that patients with mental health disorders had a significant increased risk of being under triage if they had a TBI, which is very interesting when you think about it. A lot of this is probably associated with misattribution of clinical manifestations from a traumatic brain injury to prior diagnosed mental health disorders. And as you would expect in an under triage individual, these patients had underappreciated injuries as exhibited by the ISS and AISS score. So also noted in our outcomes were that individuals that were on anticoagulant had a risk reduction. And this was where we attributed to the prior outreach methods that we initiated in 2018 to sort of identify those individuals that were high risk for TBIs and to mitigate that risk, especially those that were on known anticoagulants. So moving forward, now that we have identified that mental health disorders could be a potential comorbidity that may predispose individuals to under triage, especially in our TBI population, further outreach to our pre-hospital providers to maintain a high clinical index of suspicion for traumatic brain injuries in individuals with GCS scores, even marginally lower GCS scores as 13 as seen in this cohort of individuals. So that way we can appropriately triage those individuals and get them matched to the appropriate level of care. So.
Yeah. The floor is now open. I'm going to ask a methodological question. So these are referral hospitals in your network.
Yes, sir.
And so your missed injury was finding an injury upon their arrival at your facility that wasn't diagnosed prior to transfer?
So a lot of these patients are sitting at outside referral hospitals and they have delayed transfers. We've explored that in prior studies, and they have undiagnosed head injuries prior to being transferred over to our system.
But the decision to transfer has already been made.
Yes, sir.
Okay.
And additionally, a lot of these patients should have come directly to the level one. We have a lot of level 2 centers within our immediate area within a 30-mile radius, and they could have been directly transferred to our level 1 center if there was suspicion for a head injury.
Okay, what were the missed injuries? And then I'll let Bracken. Were they all head injuries?
Yes, sir.
Okay.
Thank you. Interesting presentation. It seems like maybe what you're alluding to in answering Dr. Daly's question is more of a question of secondary under triage, in that those patients weren't appropriately taken to the right facility the first time.
Yes, sir.
I wonder, as you were saying, you're seeing prolonged times to get those patients there, but those of us in rural environments that are trying to get patients to us as expeditiously as possible are advocating for outside facilities not to be doing additional scans that they can act on, particularly head CTs, if they don't have neurosurgical capabilities. So are you advocating for more scans prior to transfer, or are you advocating for increasing the time or shortening the time of the transfer process?
I would be advocating for shortening the time in a patient that you have a clinical suspicion for a head injury, despite any comorbidities that might explain why they have a lower GCS at the time of arrival.
And I think as an area of future investigation, look into secondary under triage and
Yes, sir.
what you were alluding to with your EMS providers, perhaps taking people to a facility that was within their destination guidelines that should have come to level 1 center to begin with.
Yes, sir.
Great, thank you.
Thank you.
All right, our next presentation is Our next presentation is Gravity Warriors Optimal Activation Criteria for Found Down Patients. Presenter is Dr. Emily Johnson from University of Colorado Health. Co-authors Finch Johnson, Rodriguez, Decker Stillman, and Chappelle.
And sorry, which is the button to advance? The screen. Okay. Thank you to the Southeastern Surgical Congress for this opportunity and to my co-authors. We have no disclosures. Patients who present to the emergency department after being found unresponsive with an unknown mechanism of injury are given the triage designation of found down. These patients often can't provide an accurate history and present after a range of potential events, including assault, intoxication, overdose, stroke, fall, assault, syncope, and cardiac arrest. This population represents a significant triage dilemma as precipitating events may represent a traumatic or a non-traumatic event. And these patients must be rapidly triaged, although the Committee on Trauma and other resources offer no definite triage criteria for found down patients. At our institution, we historically used the suspicion of trauma criteria, which includes altered mental status, confusion, seizures, intoxication, and dementia. But review of our own data suggested we were over triaging found down patients without injuries to trauma activation. And so we instead transitioned to signs of trauma, which included physical evidence of injury, including abrasions, lacerations, ecchymosis, contusions, hematomas, deformity, pain, and crepitus. The objective of this study was to identify patient characteristics and outcomes associated with traumatic injury among found down patients, and additionally to compare the signs and suspicion of trauma triage criteria. Our hypothesis was that signs of trauma would more accurately predict injury among found down patients with an unknown mechanism of injury. For our methods, we performed a retrospective review of adult found down patients presenting to a level 1 trauma center in Colorado Springs, Colorado, between January 2019 and April of 2021. Within this population, we characterized patients as injured or uninjured based on their injury severity score and compared these groups. We identified demographics and other variables, including GCS and arrival vital signs, length of stay, and mortality data to compare. We identified 415 found down patients over the 27-month study period. There was a mean age of 63.8 and 46% were female. 65.8% of these patients were found to be injured on review, and 34.2% were uninjured based on the injury severity score. Between these two groups, there was no significant difference in age, gender, arrival GCS, or vital signs. The mean injury severity score of the injured patients was 5.4, and the injured patients were more likely to have signs of trauma, 96 versus 17.6%, and uninjured patients were more likely to have .3%. In addition, we conducted a multivariate regression model, which was constructed in order to evaluate for independent predictors of injury. Signs of trauma was found to be an independent predictor of injury. Mortality and initial blood pressure were also found to be independent predictors, though initial blood pressure had a small effect size. So in summary, found down patients present a significant triage dilemma due to the inherent mystery in the mechanism of presentation. And at our institution, we recently transitioned from suspicion of trauma to signs of trauma as our triage criteria for found down patients to initiate trauma activation. This study compared injured and uninjured found down patients, and we found that signs of trauma can predict injury with high sensitivity and moderate specificity. in this population. And so we'd conclude that the signs of trauma can be a valuable indicator of injury and can be an important triage criteria for trauma activation. Limitations include, this is a retrospective review, and it was performed at a single institution using an institutional trauma registry. I'd like to thank the Southeastern Surgical Congress, and I'll take any questions.
Thank you, Dr. Johnson. The floor is open for a question or two. I'll start with. Yeah,
So who determines the signs of trauma, and how did you educate, say, your EMS crew as to what is a pressure lesion compared to a contusion?
Yeah, so the signs of trauma, it's a combination of the EMS, as you mentioned, and the nurse who coordinates the trauma activations in the emergency department. I couldn't comment on exactly how they were educated on using this criteria, but it was, essentially we were moving from this kind of vague combination of confusion and in the suspicion of trauma criteria to like, do they have physical signs of injury?
So I assume that there's probably no national standard in this space. So what's the next step for you and for this project?
So the first next step would be broadening our population to the, we actually have 3 level 1 trauma centers within our health system in Colorado. So broadening it to see if we can get the same results at those institutions. Colorado Springs is a little more rural than the Denver population, so seeing if it applies more broadly at other institutions, and then hopefully trying to move towards more of a prospective evaluation of this criteria in triaging.
Yeah, I mean, I'll probably say that should be the first next step, is to see if we can broaden this to not just a regional, but potentially a national prospective trial. I mean, the predictive value difference between the 2 methods, I think, was remarkable and probably should have some impact.
Mhm.
Yes, ma'am.
Keelan Roach from Johnson City. It's really interesting. I found down patients are always kind of a conundrum and often uninjured. Did you identify what injuries you may have missed without using the symptoms or the initial, any injuries you may have missed with the new system?
You're talking about injured patients that we missed.
Yeah.
As discussed, the sensitivity of the signs of trauma was like 96% for finding those injured patients. So in large, we identified almost all of the injured patients using the signs of trauma. I am not aware of, what that 4% would include, which patients were missed in that cohort. But if I had to guess, it's probably more like a head trauma that we were missing, like syncopal episodes with ultimate head trauma.
Our next paper is Cultural and Linguistic Adaptations of Stop the Bleed in Multi-Ethnic Refugee Communities. It'll be presented by Darir Abdullahi, and his co-authors include Zaidan O'Connor, Feinberg, Asker, Meyer, Butler, Harad, Rohrbach, Rashid, Koganti, Williams, and Smith.
Thank you very much to the Southeast Surgical Congress for having me here today. So cultural and linguistic adaptation to stop the bleed in a multi-ethnic refugee community. We have no disclosures. A little bit about the background. So life-threatening hemorrhage is the leading cause of preventable death after an injury. ACS developed the Stop the Bleed campaign in 2015, and currently this is only offered in English and in Spanish. In a different study that I was part of at the University of Washington in 2019 to 2020, they led the first effort to establish a connection between emergency medical services and the local Somali refugee communities in the King County area. The study showed feasibility of implementation and evidence of increased bleeding control within that Somali community. Now, what we know, some of the factors with pre-hospital disparities for limited English proficiency populations include there's lower awareness and utilization of EMS services. There's lower rates and quality of bystander CPR. There's increased time to initiating bystander CPR, and there's delays in calling 911. So what we did is we worked in Clarkston, which is the most ethnically diverse square mile in the southeast of the US, with refugees from over 50 different countries and over 60 different languages spoken. So it's a great sample population to achieve the work that we need to do. The way that we developed it is we used a framework of Stop the Bleed. We culturally adapted it, translated it with the help of local stakeholders from each of these communities, Somali, Burmese, Arabic, and Swahili. We advertised the programming through social formats like WhatsApp, Facebook, and we went through each of the highly visited areas that these communities usually visits, like mosques and churches, and the whole goal being to increase knowledge and self-efficacy of individuals within the above communities regarding bystander response in emergency situations, personal protection against blood, information concerning the Good Samaritan law, and hands-on simulations. So we use two very important theories when developing this. There's theory of planned behavior, which says that people are much more likely to enact certain behaviors when they feel they can do it successfully. Then there's social support theory, which tells us increasing interpersonal support will help people to be better prepared for the future in regards to accessing EMS and bystander skills. And our model to the right it shows a very important concept here, that it's a bi-directional method of learning. So it's a collaborative learning and skills exchange between refugee community and physicians. The physicians are providing emergency skills, but the physicians are also receiving because they're gaining cultural knowledge and are better able to serve these populations. Down below is our goal, utilizing the social support theory and theory of planned behavior, where we have increased rate of bystander intervention. We have improved utilization of EMS and increased control and reduction of disparities in emergency outcome. So the program was evaluated through a few different aspects, including oral feedback and written responses. This is our index programming, and there have been two others since. We had 46 community participants, 7 physicians and residents, and 3 community leaders and translators and interpreters. We noticed an increased knowledge of 43% from previous, increased confidence of 26%, and 61% felt more comfortable performing these tasks. And 87% of the participants felt comfortable teaching others. So just a brief chart kind of explaining the most statistically significant difference in terms of some of the questions that were asked and their responses in the pre and post intervention. So a lot of these are knowledge based on technique, and it does show that they have better understanding of how to appropriately perform Stop the Bleed. So some of the feedback, I'm not going to read all of them, but some of them, as you could see, the value for one of the participants was the questions that other people ask, things that they didn't even think about, and all the hands-on activities. Some of the important feedback we got was they appreciated the hands-on training and the small group sharing of culture. They wanted a shorter lecture period. And we had a lot of community members that didn't sign up who came, such as communities who speak Bengali, Farsi, Hindi, Punjabi, Nepalese. All of them came actually during and after the session and wanted this to be done for their communities as well. And the participants appreciated certificates and gift cards at the end of the session. There were some limitations, of course. We did not incorporate EMS and police into the activities of the first pilot study. There may have been differences in interpretation and translation of the questions. There was low response rate for the open-ended questions, and the recruitment efforts were significantly impacted by COVID-19, and there was possible selection bias. What are some of the lessons learned? Translation of material like this is extremely challenging and time-consuming. Certificates for completion were very important, and COVID-19 pandemic and fear amongst refugee and immigrant communities limiting participation, however, giving insight into the utility of virtual training efforts. So in conclusion, Stop the Bleed training, translated and interpreted into varying languages, is a feasible and acceptable program, easily transmittable to limited English proficiency populations, and shown to increase bleeding control knowledge and self-efficacy among English, Somali, Arabic, and Burmese individuals. In future sessions, we will include requested languages like Bengali, Farsi, and Nepali. And we are currently working on creating a working template and a blueprint that can be utilized across the country with the varying languages. These are some of the co-authors and the people who have significantly helped. Thank you, and thank you to SESIC.
We'll open the floor now. I do have questions. In communities that don't have such an engaged population to act as translators, are any of these languages available, say, on Google Translate that would make communication and learning easy, or are there such difference in dialects that it really depends on that translator to interpret the Stop the Bleed training?
Thank you for that question. There is a significant difference in dialect and perception of how people communicate in all these different languages. Even in just the Swahili, there were so many different ways that it was communicated that some people within the same community spoke a different dialect. So it's really hard to do it with Google Translator, and it's the best method is, if possible, have someone from the community who is a stakeholder with the knowledge and expertise and education to perform it. And if not, have someone virtually from another part of the country available who can help virtually.
Okay. Congratulations, Dr. Abdullahi. Great local initiative and effort. Are you guys having any conversation with, organizations like the college about how to sort of elevate this, not just to your, small little region, but regionally and nationally?
Yes, sir, actually. With Dr. Randy Smith, we are working on making this more publicly available across the country through the college.
Very good. Congratulations.
Thank you very
Thank
much.
you. Our next presentation is hyperfibrinogenemic massive transfusion trauma patients experience worse outcomes. The presenter is Dr. Mitchell Parker from University of Tennessee Medical Center. Co-authors are Crowder, Miles, Harrell, and Maxwell.
Thank you. My name is Mitch Parker. I'm here representing the University of Tennessee in Chattanooga. Thank you to the Southeastern for allowing us to present our work titled Hypofibrinogenemic Massive Transfusion Trauma Patients Experience Worse Outcomes. So to begin, trauma-induced coagulopathy results in significant morbidity and mortality. Up to about 40% of mortality is due to traumatic hemorrhage. Fibrinogen tends to be one of the first of the procoagulants to deplete in massive transfusion. And there's many studies that support that low fibrinogen levels during traumatic hemorrhage are associated with worse clinical outcomes in this population. Our institution utilizes about 10 units of cryoprecipitate every other round of massive for fibrinogen replacement, although the optimal ratio of cryo to PRBCs, FFP, and platelets remains relatively undefined in the trauma resuscitation guidelines. So the aim of our study was to investigate the relationship of admission fibrinogen level with outcomes in trauma patients undergoing massive transfusion. So we established a prospective practice management guideline that focused on obtaining a tag and a fibrinogen level at the start and conclusion of massive transfusion on all of the patients. This occurred over a 2-year period at our level 1 trauma center from December 2019 to 2021. And these patients were broken into 2 cohorts based on their admission fibrinogen level, with the cutoff of hypofibrinogenemia being less than 200 milligrams per deciliter. So inclusion criteria were all adult trauma patients greater than 18 years of age that were non-pregnant. Primary outcome of the study was mortality, and secondary outcomes were post-massive fibrinogen levels, as well as the total amount of blood products transfused. So a total of 96 patients met inclusion criteria. Majority of the patients that were excluded were non-traumatic mechanisms of injury requiring massive transfusion. Median admission fibrinogen level of this cohort was roughly 170 milligrams per deciliter. And as I will discuss, there were significant differences between these two groups in the TEG parameters, the amount of blood products transfused, and overall mortality. So I wanted to draw your attention. This is some of the significant differences between these two groups with regards to their demographic data. There was about a 20-year age difference between the hypofibrinogenemic population and the normal or high level. Also, with regards to admission lactate and admission INR, the hypofibrinogenemic population had elevations in both of those, showing a worse coagulopathy profile. With regards to the TEG data that we obtained, there was statistic significance with the alpha angle, K time, and max amplitude between these two groups, again supporting that there was worse coagulopathy in the patients with low fibrinogen prior to massive. And with regards to transfusion data, the patients who were hypofibrinogenemic received about double the amount of blood products during transfusion. There was 10 units versus 5 of PRBCs, 9 versus 4 units of FFP, and 2 versus 1 units of platelets. And again, looking at mortality, there was a 50% mortality rate in the patients with low fibrinogen on admission compared to a 23.5% mortality rate, which reached significance. So we ran a univariable, multivariable regression analysis looking at risk factors for mortality. And again, increased fibrinogen was protective of mortality, but the risk factors were increased age, decreased admission GCS, and elevated injury severity score across both models. And this shows that of patients that survived massive transfusion, they showed a significant increase in their fibrinogen levels to roughly 230 milligrams per deciliter from roughly 170 pre-transfusion. So in conclusion, massive transfusion trauma patients with low admission fibrinogen levels demonstrate increased mortality. Mortality risk factors in this population include older age, decreased GCS, and elevated injury severity score. These patients also demonstrate worse coagulopathy profiles, including TEG parameters, and they required about double the amount of blood products during massive transfusion. And patients who survived massive showed that they had significantly higher fibrinogen levels following our institutional guidelines with our cryoprecipitate. So some limitations of the study. This was a single site retrospective study. Only 96 patients met inclusion criteria over this 2-year study duration. We define massive transfusion based on the firing of massive in these patients rather than the amount of total blood products that they received. And again, some of our conclusions after this, we weren't able to get coagulation profiles or tags on patients who did not survive, and that limits our comparisons between survivors and non-survivors. Appreciate your time. I'd be happy to take any questions.
Thank you, Dr. Parker. The floor is open for questions.
So have you changed your MTP?
We have not. No, we did show, with the results, I think this was the first time we actually tested our guidelines, and it did show that of the patients who survived, they had that significant increase.
So have you changed your MTP? Will you change your MTP?
Not based on, what we've seen.
Why not?
So I think what we've done is that we've shown that, so with regards to the guidelines, replacing the fibrinogen above the 150 to 200 milligram per deciliter level, the patients that survived massive shown that their average level was around 230. And we don't have enough evidence to show that giving more cryoprecipitate may increase that. Maybe another avenue for future studies is if we give more cryo, will outcomes improve, especially with regards to mortality.
Second question, do you have time from injury to arrival or to your first fibrinogen level?
In our data collection, we do have the time of arrival to our facility. I don't know if that was included in the study, but we do have that data available.
Yeah. Was there an inflection point in terms of fibrinogen where there's a clear correlation with, beyond this point, there's a decrease in mortality?
So we did look at that. Some of the preliminary data that we have shows that with a fibrinogen level of around 75, there was almost a 100% mortality rate. So that's something that we'd like to study in the future to break down the patients basically risk stratify them based on their admission fibrinogen.
Yeah, because I think ultimately that's what you want is there an inflection point, and then beyond the inflection point, is there a graded impact? So if your fibrinogen is 200 versus 230 versus 250,
Right.
is there an impact on mortality?
Mhm.
So great presentation. Thank you.
sir.
Our final paper, poor outcomes of patients from delayed care after ground level falls, presented by Matthew Hurd from East Tennessee State University, co-authors Suresh, Leonard, and Burns.
Okay. Good morning, everyone. I'm Matt Hurd. I'm PGY2 in general surgery at East Tennessee State University. I'd like to thank the Southeastern for the opportunity to present our study entitled Poor Outcomes of Patients from Delayed Care After Ground Level Falls. We have no disclosures. As I'm sure many of you are aware, ground level falls are a common cause of morbidity, mortality, and trauma patients. Per the CDC, they report roughly an incidence of 3 million ground level falls per year. In fact, this is the most common mechanism of injury at our level 1 trauma center in Johnson City, Tennessee. And it comprises about 38% of entries into our trauma registry each year. It's also been shown in the literature that delayed presentation does lead to worsened outcomes in multiple medical and surgical conditions. However, research on this topic in the trauma literature is limited. So our objective was to determine if those who suffer a fall and have delayed presentations have a worse outcome. To do this, we performed a single institution retrospective analysis of our trauma registry from January 1st, 2017 to December 31st, 2021. And any adult patient who presented to our ED after a fall was included and then grouped based on their time to presentation, whether that was within or greater than 24 hours after their injury. We gathered various outcome and demographic measures from the registry and performed various statistical analyses for our results. As you can see here, our study included 4,018 patients over the study period. Only a small minority of them, roughly 5% or 200, had a delayed presentation. 2/3 of the study population were female, and patients in the delayed group will more likely be younger in age and male. Additionally, we had statistically significant differences in outcomes between the two groups with increased hospital and ICU length of stay, as well as ventilator days. But most notably, mortality was almost doubled in the delayed presentation group from 3.5 to 6.5%. So as shown by our study results, previous observations of worsened outcomes with delayed presentation has been supported in ground level falls. And this begs the question, is this due to, in our area, an inherent distrust of medical providers that has been well described, or a lack of access to care in Appalachia? So when we looked at the literature, particularly in this topic, we noted only one paper that looked into this. This was performed up in Rhode Island at Brown. And we noted that there was a sharp contrast in our results compared to theirs. They discovered no association with demographics or outcomes based on time to presentation, and they had also chosen the 24-hour time mark. We did note a higher mean injury severity score in our study, which may suggest our patients have a lower baseline with a decreased reserve to recover after a trauma. So it kind of also helps us to understand, is this an access to care issue, or does it have to do with just an unhealthier baseline? In this case, I'd argue both. As in general, Appalachia is considered roughly 42% rural. And in these areas, it's been shown to have both lower supply of PCPs and subspecialty providers, in addition to just an unhealthier baseline, with a 2021 report indicating that Appalachian people performed worse in 33 of 41 indicators. So where do we go from here? There are kind of multiple paths we could take. We can reach out to our primary care colleagues to help reach our patients before they fall. Maybe addressing some potentially inappropriate medications the patients may be prescribed. We could also provide some outreach to nursing homes to emphasize the importance of timely care after falls from their center, or even enacting stricter discharge criteria, discussions with our PT colleagues is in regards to discharge disposition, as well as pre-discharge education to help limit readmission. So limitations, this is a single institution retrospective study, so our findings may not be applicable to other institutions. But as noted, there may also be other regional and population differences unaccounted for. Either way, this is very important for our patients as it directly affects trauma care in our region. And also, given the study that we only looked at outcomes, demographics, and time to presentation, there may be some unmeasured confounding variables. So the fact of the matter is this: patients who suffered a ground level fall and had delayed presentation for evaluation had worsened outcomes. And I will take any questions.
So I have a couple questions. What were the injury patterns that you saw in your delayed presentation pattern? Was it mostly head injury or was it chest injury? And is that why you had such a difference in ventilator days?
So we didn't specifically look at injury patterns, but it's something we could explore.
The other question I would have is, were you able to discern how many of these people lived alone without close contact to others, which would be another social determinant of health?
Right. Just given the nature of the retrospective study, that is something we've discussed, and that's what we want to look for in the future. Whether do these patients, are they stubborn? They don't want to seek care? Do they not have the social support they need? Or even do they have kind of an inaccurate estimation of the severity of their injury? That's something we'd like to look into.
Nice presentation, Dr. Hurd. You sort of alluded to potential confounders between the two cohorts, such as maybe pre-existing conditions. What's the plan to sort of address those potential confounders, even with this current cohort that you're working with?
Right. We'd actually previously presented this work, and we've gotten some great feedback about potentially looking at other comorbidity indices that may help to kind of suss out those issues. Given the kind of the timing of when that was, the study had closed with our IRB, so we were unable to kind of go back and assess that.
I think that'll be important to do. And the nice thing about the sample is that you have over 3,000 in the non-delayed presentation, so you should be able to find a cohort in that sample to match with your delayed cohort to be able to address some of those confounders. But very nice presentation.
Thank you.
All right. Thank you all. That concludes our session. Thank you guys for staying with us during this last day of the Southeastern Surgical Congress. And as always, hard to be this late into a conference. So we appreciate your attendance, your engagement. Happy Valentine's Day. Safe travels for those of you who are leaving before the last sessions. All right. Thank you very much.